This voiceover is going to cover pituitary and adrenal gland disorders. This image shows the cranium. You'll notice the pituitary gland. It is quite small, but it is considered the master gland of the endocrine system. The anterior pituitary gland secretes growth hormone, prolactin, adrenocorticotropic hormone, thyroid-stimulating hormone, follicle-stimulating hormone, and luteinizing hormone. These hormones affect growth, sexual maturation, reproduction, metabolism, stress response, and fluid balance. The posterior pituitary secretes the hormone vasopressin and oxytocin. Vasopressin has a key role in the regulation of water balance and serum osmolarity. For the anterior pituitary disorders, we are going to primarily focus on growth hormone. When there's too much growth hormone, it results in acromegaly in adults and giantism in the pediatric population. Acromegaly is a rare condition characterized by an overproduction of growth hormone. It often occurs because of a benign growth hormone secreting pituitary adenoma or tumor. The excess in growth hormone results in an overgrowth of soft tissues and bones in the hands, feet, and face. The bones of the arms and the legs do not typically grow longer, as the problem develops after epiphyseal closure. When there is too little growth hormone, it results in a short stature. Hyperpituitarianism is a rare disorder that involves a decrease in one or more of the pituitary hormones, most commonly growth hormone. The usual cause of pituitary hypofunction is a pituitary tumor. Other causes include autoimmune disorders, infections, pituitary infarction, or destruction of the pituitary gland from either trauma, radiation, or surgery. Blacks have a higher incidence of pituitary tumors than other ethnic groups. Here are some images that show acromegaly. Physical changes resulting from excess growth hormone in adults occurs slowly over many years and may go unnoticed. Life expectancy is reduced by 5 to 10 years. People with acromegaly are prone to cardiovascular disease, diabetes, and colorectal cancer. Clinical manifestations of acromegaly include thickening or enlargement of the bony and soft tissues of the face, feet, and head, fatigue, depression, body image problems, muscle weakness and joint pain, carpal tunnel syndrome, peripheral neuropathy, tongue enlargement, which often results in dental and speech problems, deepening of the voice, and this is due to hypertrophy of the vocal cords, sleep apnea due to upper airway narrowing and obstruction, thick, leathery, oily skin, vision changes due to pressure on the optic nerve from a pituitary adenoma, headaches, glucose intolerance and diabetes symptoms such as polydipsia and polyuria, and sexual dysfunction. Diagnosing acromegaly includes obtaining a thorough history and physical. There's several blood tests that can be done, including IGF-1. As growth hormone levels rise, so don't IGF-1 levels. This test is very reliable. There's also an oral glucose tolerance test. During the oral glucose tolerance test, growth hormone concentration normally falls because glucose inhibits growth hormone secretion. A MRI or CAT scan may also be done to detect pituitary adenomas, and an eye examination is done because there could be increased pressure on the optic nerve due to a tumor. Treatment for acromegaly includes surgically removing the pituitary gland. This is often first-line treatment. It results in immediate reduction of growth hormone levels. The client will require replacement of hormones. Other treatments include drug therapy with the use of the drug octreotide. This drug reduces growth hormone levels. And also radiation therapy. Radiation may be needed following surgery for larger tumors. The patient's prognosis depends on the age at onset, age when treatment started, and the tumor size. The overall goal is to return the patient's growth hormone level to normal. Treatment can stop bone growth and reverse tissue hypertrophy. However, sleep apnea, diabetes, and cardiac problems may persist. Growth hormone deficiency will be covered next. Clients with hypofunction of the pituitary gland or deficiency in growth hormone may present with fatigue, headaches, vision changes, loss of smell, nausea and vomiting, seizures, and dwarfism. Diagnostics for growth hormone deficiency are the same as the diagnostics for acromegaly. Treatment for growth hormone deficiency includes surgery and radiation therapy, followed by hormonal therapy. Hormone therapy is contraindicated in those with phlebitis, pulmonary embolism, breast cancer, or prostate cancer. For posterior pituitary disorders, we are going to focus primarily on antidiuretic hormone, or ADH. Too much antidiuretic hormone results in syndrome of inappropriate antidiuretic hormone, or SIADH. Too little antidiuretic hormone results in diabetes insipidus. Syndrome of inappropriate antidiuretic hormone, or SIADH, results from an overproduction of ADH or the release of ADH despite normal or low plasma osmolarity. An increase of ADH results in increased water absorption in the renal tubules, increased intravascular fluid volume, dilutional hyponatremia, and decreased serum osmolarity. For SIADH, think low and wet, low sodium, and excess fluid in the body. There are several causes of SIADH. Some include cancer, specifically small cell lung cancer, trauma to the head, infection, which results in encephalitis and meningitis, various lung diseases such as COPD, pneumonia, and tuberculosis, and numerous drug therapies. Clinical manifestations of SIADH include low urine output, increased body weight and fluid retention, thirst, dyspnea on exertion, fatigue, and hyponatremia. Symptoms of hyponatremia include muscle cramping, irritability, headache, vomiting, confusion, seizures, and coma. As the nurse, you will want to monitor INOs, vital signs, heart and lung sounds, and obtain daily weights. It is important to monitor for symptoms of hyponatremia. Treatment of SIADH includes treating the underlying cause, avoiding or discontinuing medications that stimulate ADH release, vasopressin antagonists, fluid restriction of 500 to 1,000 milliliters a day, depending on the severity, oral care, ice chips, and sugarless chewing gum, Administration of Lasix. Keep in mind, Lasix does decrease some electrolytes such as potassium, so electrolyte supplementation may be needed. Initiation of seizure and fall precautions, and administration of IV hypertonic saline solution, typically 3% sodium chloride. Diabetes insipidus, or DI, is caused by a deficiency of production or secretion of ADH or a decreased renal response to ADH. The decrease in ADH results in fluid and electrolyte imbalances caused by excessive urine output and increased serum osmolarity. When you think of diabetes insipidus, think high and dry. The client has a high sodium and a lack of water in the body. There is central or neurogenic DI, which is the most common. It can be caused by head trauma, brain tumor, or CNS infections. There's also nephrogenic DI, caused by drug therapy such as lithium, renal damage, or hereditary renal disease. Clinical manifestations of diabetes insipidus include polyuria, typically greater than 200 milliliters an hour of urine output, polydipsia, a low specific gravity and urine osmolarity, and a high sodium level. The client may exhibit symptoms of dehydration, including dry mucous membranes, skin turgor greater than 3 seconds, weight loss, tachycardia, hypotension, and hypernatremia symptoms such as irritability, mental dullness, and coma. As the nurse, you will monitor blood pressure, heart rate, level of consciousness, intake and output, and daily weights. Treatment of diabetes insipidus includes treating the underlying cause, placing the client on a low sodium diet, less than 3 grams per day, pushing fluids, either PO or IV, and administering desmopressin and vasopressin. In this image, you'll see the 2 adrenal glands that sit on top of the kidneys, and within the adrenal glands is the adrenal cortex. The adrenal cortex steroid hormones have 3 main classifications: glucocorticoids, mineralocorticoids, and androgens. Glucocorticoids regulate metabolism, increase blood glucose levels, and are critical in the physiologic stress response. The primary glucocorticoid is cortisol. Mineralocorticoids regulate sodium and potassium. The primary mineralocorticoid is aldosterone. Androgens contribute to growth and development in both genders and to sexual development in men. Adrenocortical insufficiency, also known as Addison's disease, results in the reduction of all 3 classes of adrenal corticosteroids. Causes of Addison's disease include an autoimmune response, tuberculosis, fungal infections, AIDS, and cancer. JFK was known to have Addison's disease. Clinical manifestations of Addison's disease include anorexia, nausea, vomiting, diarrhea, progressive weakness and fatigue, weight loss, bronze-colored skin pigmentation, and this is prominent in sun-exposed areas, pressure points, and creases, abdominal and joint pain, headache, orthostatic hypotension, salt cravings, irritability, and depression. Clinical manifestations do not tend to become evident until 90% of the adrenal cortex is destroyed. The disease is often advanced at the time of diagnosis. The clinical manifestations typically have a slow, insidious onset. Diagnosing Addison disease involves obtaining a thorough history and physical, performing a ACTH stimulation test, labs, ECG, CAT scan, or MRI. Treatment of Addison's disease includes managing the underlying cause, lifelong hormonal therapy. Hydrocortisone has both glucocorticoid and mineralocorticoid properties. DHEA for women, added salt to the diet. Patients with Addison's disease need an increase in corticosteroid dosage, especially in stressful situations, to prevent Addisonian crisis. It's important for the nurse to educate on signs and symptoms of corticosteroid deficiency and excess. Patients should wear a medic alert bracelet. They should carry hydrocortisone IM and syringes in case of emergency. The patient and family should be educated on how to administer IM injections. Addisonian crisis is a life-threatening crisis that is triggered by stress due to infection, surgery, psychological distress, sudden withdrawal of corticosteroid hormone therapy, adrenal surgery, sudden pituitary gland destruction. I used the example of JFK, and as you would expect, he had a very stressful job, so keep that in mind. Symptoms of Addisonian crisis include hypotension, tachycardia, dehydration, hyponatremia, hyperkalemia, hypoglycemia, fever, weakness, and confusion. The hypotension may lead to shock. Treatment includes rapid rehydration and electrolyte replacement, as well as high dose of hydrocortisone replacement. Cushing's disease results from chronic exposure to excess corticosteroids, particularly glucocorticoids. Causes of Cushing's disease can be from chronic exposure to excess corticosteroids, ACTH secreting pituitary adenomas, or primary adrenal tumors. Clinical manifestations of Cushing's disease includes weight gain. This is due to an accumulation of adipose tissue, most often found in the trunk, face, or cervical areas. Other clinical manifestations include hyperglycemia, muscle wasting and weakness, osteoporosis and back pain, loss of collagen, purplish red striae on the abdomen, breast, and buttocks, delayed wound healing, hypokalemia, fluid retention, acne, development of male characteristics or menstrual issues in women, and feminization or impotence in men. To diagnose Cushing's disease, the client may undergo a CT scan or MRI to detect a tumor. There needs to be confirmation in the increase in plasma cortisol levels, and this can be done a few ways. Through a late-night salivary cortisol test, a low-dose dexamethasone suppression test, or a 24-hour urine cortisol. Treatment of Cushing's disease includes surgery, radiation therapy, or drug therapy, also known as medical adrenalectomy. The goal is to normalize hormone secretion. The specific treatment depends on the underlying cause.